have been given the task to talk about advanced care planning. It is not new. However, in our region of Malaysia and maybe Indonesia, it is something new, and there's no actual national program for it. However, we are starting to sensitize and starting to advocate for advanced care planning. So what I think the majority of audience today would be questioning or asking, what is actually advanced care plan? And here I am today, this afternoon, to enhance everyone regarding what is advanced care plan. So I will just share with you the outline of my lecture today. Firstly, I would define what is ACP. Advanced care plan is also known as ACP. And then I will talk a bit about why is the need of ACP, what are the components that are in ACP, how do we or as a caregiver or a patient choose a proxy, and what is the process in doing a ACP. So advanced care plan, just a short introduction. Advanced care plan is not about just doing it while at old age. It can be done at any age because any one of us may be have to deal with a medical crisis where we may be left too ill or unable to make our healthcare decision. Thus, a ACP will then be useful to your next of kin or even the healthcare providers to provide care for you. Even if you are not sick now, planning for healthcare in future is an important step to make sure that we get what we want from the medical care when we are unable to speak for ourselves, and when the doctors or even your next of kin are making medical decision for you. So what is ACP? ACP is an ongoing process of communication among yourself, the patient, our patients, families, or even their next of kin, segregate decision maker and healthcare providers regarding illness or prognostication information, treatment option about patients' life goals, values, and wishes for treatment or future treatment, so that whatever we can provide as a healthcare provider to make sure that it is in accordance to the patient's preference. So ACP allows an individual to plan for future healthcare in the event of when they are unable to make a decision. ACP can be conducted in any healthy individual and can begin anytime when an illness is being diagnosed, such as an illness of maybe cancer or even an organ damage or even progressive neurological disorders. So ACP is an ongoing process. So in summary, what is the purpose of ACP? It is a medical plan to provide people the opportunity to plan for their future medical care and support. This would include medical therapy, even non-medical therapy, while they have the capacity to do it. So ACP is a discussion to be done while the person or the patient have the capacity to discuss, to plan for their future medical and non-medical care. So why does it matter? Like I said, ACP facilitate the optimal medical and non-medical care option throughout the disease of a patient, so that we are able to at least be aware of the patient's preference, values, and goals of care. However, ACP does not increase somebody's or the patient's distress or even the segregate decision maker distress, because it is an ongoing process and it is more into whether these patients are willing to have this discussion. It's not compulsory, or in the sense that the patient must do it if the physician asks for it. It is an open discussion. Okay, so like I said, where is the where in this region or in this world would be would the ACP be available? Here in this picture that I have in my slide, have shown that UK, US, Australia, New Zealand, even the neighboring Singapore and Taiwan would have national ACP program at this point, which are all legalized. However, in Malaysia, we do not have any national program at the moment. However, there have been regional initiative by several organizations, even individual organizations such as Hospital Selayang in Kuala Lumpur, in Sarawak, in Sabah, Sarawak, and also Hospice Malaysia. However, it has not been a national program. I think it's still very new. However, this ACP should be well known to all healthcare providers and sensitized so that it can be given to all patients in need of ACP. So, who are involved in ACP? Of course, the patient, his or her segregate decision maker, the family and the loved one, the next of kin, and of course the involved clinician in charge of the patient. So what are the common ACP decisions that have to be done that we require a ACP document? Sometimes there in decision must be made in situation of emergency to make sure that the patients are alive or being treated accordingly. So some of the decisions that may come up during this period of emergency or related to period of emergency include cardiorespiratory resuscitation like CPR, ventilation use, intubation, non-invasive ventilation, artificial nutrition such as tube feeding, NG feeding, artificial hydration, comfort care for symptom control, and even end-of-life care, which also includes organ donation and also the DNAR status. So I would now summarize the issues or questions that are usually addressed in ACP. Usually there are 5. We normally, if you look into literature, they will say about 5 wishes. So the number 1 would be the person I want to make, I want to appoint to make care or make decision for me when I can't. So this refers to proxy or segregate decision maker that a patient's appoint to make medical decision on behalf of the patient when they are unable to speak. The second question or issue would be the kind of medical treatment that the patient want or do not want. This would refer more about patient's treatment option, support, life support treatment. What would they want and what would they not want during period of illness? It can be when patients are admitted for infection. Would they want IV antibiotics only, or would oral antibiotic be sufficient, or would they feel that if they are progressing due to the illness itself, would they want just comfort care or maybe more aggressive life prolonging intervention? So these are types of medical therapy we are talking about. And then the next third issue would how comfortable would the patient want? So what are the methods that they look into for comfort care? For instance, symptom control. If they have pain, would they like to have opioids? Some of them have phobia about using opiates or even stigma because they do want to have some amount of consciousness so they can have continuity of conversation with their loved ones, or they prefer, even though they are bedbound, they would like to be showered. So these are important things that we may have to address in ACP. Some would also ask about where the care should be? Is it in the home or even in nursing home or even hospice? So the number 4 question would be, how would I want people to treat me? So this relate to personal matters to the patient, such as, like I said, whether they want to be at home, want someone to be beside them all the time. Would they want any spiritual leaders to be around them, to pray with them? And the last question to address would be, what would the patient want the loved ones to know? This refer usually to their last wishes, regarding maybe sometimes also about legacy, leaving behind what they want to be remembered as. So these are some of the, I would say, summary of what is ACP questions we ask or we would like to compile in. And to further explain, I have some examples. So in ACP, it would be like that. Some of the questions will be, if you develop a stroke or maybe a heart attack or even a non non-curable illness. For instance, my question is here: if you have a stroke that leaves you unable to move and then your heart stops, would you want CPR? Or if you were also mentally impaired by the stroke, does your decision making change? So initially, if the patient say, okay, if I have a stroke, my heart stop, I think let nature take the process. If I have a stroke, my heart stop, I want to be on a ventilator, I want to be revived. But if I have been also mentally impaired, I do not want to be revived. These are things that may have to be discussed in ACP. Some other questions include, what if you are in pain at end of life? Do you want medication to treat the pain? Even though this medication can cause drowsiness or make you more lethargy, or even if you are permanently unconscious and then develop pneumonia, would you want antibiotics to be placed on a ventilator? So these are common discussion we have in ACP. So components of ACP. Firstly, there should be understanding, reflection, and discussion of the patient's individual health state and the care option in context of the patient's personal values and goals. With that at the back of your mind and knowledge, then you formulate and document a plan for his medical care future. Okay, so then we communicate whatever we have planned with the loved one, next of kin, and even the team of medical doctors taking care of the patient. At the same time, this plan should be reviewed periodically. That means it should be reviewed regularly to ensure it remains consistent with the values and goals of the patient, even especially when there is change in the health condition. For instance, maybe he's having a disease progression. So when with every change in his health condition, we should review the ACP plan and discuss again regarding the values and goals of care for or even preference for the patient. And then making sure the plan is carried out according to his circumstances. So with ACP, it's important to talk about understanding of the patient's illness, prognostication, and also what are the treatment options. We talk about expectations and goals of patient. What would they feel their expectations are with the illness, the treatment, what are the goals of care for long-term and short-term. Okay, so discussion with healthcare providers. We should discuss disease trajectory. So a patient should be, the discussion with the clinician should be talking about what is the natural history of the disease, what are things that we look out for acute exacerbation or concurrent diseases that may aggravate or even make the prognosis worse, or even treatment that can look into improving prognostication. So these are things that we have to have discussion with the healthcare providers and patient. Sometimes when we discuss this, it's not only about talking how long the patient have, but what will happen, what are the expectation of the illness, and what are the changes that we are expecting the patient to develop or even experience. So when clinicians talk about disease trajectory to patients and also their healthcare to their health medical segregate or proxy, we allow these patients to understand what is going on and what would their expectation in healthcare be in future, so that we as clinician be able to deliver appropriate care and that is appropriate at the patient's time of illness. So if they need palliative care, maybe they can be referred to or any other services. So again, with this also, with this knowledge, the patient and the carers can better understand the why they are feeling certain symptoms, how these certain symptoms develop, and with this, they have better control of their situation and empower patients to be able to cope with what's going on with them and also discuss about their expectation and values and care that they would prefer. So different patients would benefit from different goals or preference of care. So with that, we can have realistic discussion with patient and family that sometimes doing everything that can be done for a possible cure for a patient may not be exactly accurate or correct. It may be misdirected. We acknowledge that patients will decline and death is unavoidable. However, what we can do is prevent unnecessary admission to hospital or even aggressive treatments that may not benefit from for the patient. We allow the options of supportive care focusing on quality of life and symptom control to patient, and this can be done early and also frequently reviewed. Again, we optimize quality of life. With this also, we can also start planning for good death if is appropriate for patient. And again, with ACP, patients are able to gain control over their illnesses because their knowledge about what is going on and how the illness is progressing is there. So they are in control of what is going on with their body, with their illness, and they can guide it according to their own preference. When to start? Ideally, we should take or start discussing about ACP in the outpatient setting. Why? Usually, patients in the outpatient setting, they are relatively their health is relatively stable. Usually, we do not like to talk about ACP in the inpatient setting because sometimes when they are admitted, they are usually acutely ill, they're more lethargic, they cannot retain long conversation. So these are the reasons. However, if you think it's appropriate to start ACP discussion in the inpatient, please go ahead. It should be initiated by their physician. Who are the physician? Anyone in the team, whoever the patient is comfortable to discuss ACP, or even any physician who are comfortable to discuss ACP with the patient should initiate the discussion. However, it's any initiation, but it's not a forced decision to continue to finish up the conversation. It is a timely and take over several settings. So, what are the clinical roles in supporting ACP for the doctors? So, the doctor should systematically incorporate ACP into patient care. We should introduce this topic in the outpatient setting, like I said just now, because of the period of stability of health, you should clarify what the patient's understanding or concern and what are the important things in event that they cannot make a decision. Here, I would like to highlight that we are talking about patients' values, their goals, their wishes, and then of course, we ascertain patients and families' understanding about the disease process and also prognosis. What are the available options? Again, this is a very important time to make sure that if there's any misunderstanding or inconsistency regarding the understanding, to clarify and to narrow the gap of maybe miscommunication between the understanding of disease progress or prognosis or even treatment. Here, I would like to also highlight that ACP is not about talking about withholding or withdrawing treatment. This is not the goal of ACP. It's more about a plan of what would be the best medical or non-medical option for this patient in the event of this patient unable to make his own medical or decision later in future. So again here, remember I talked about proxy and surrogate decision maker. Here the clinician should ensure that all key stakeholders, that means the one I mentioned earlier, should be on the same page. That means should have the almost similar understanding of the medical condition, the care option, treatment option, and even patient's value and goals, so that they are able to follow and also carry out what the patient's preference are. Here, ensure transparency of the ACP. That means make it available if it's at home. I do encourage patient in UM, basically in my center, what happened is once we do a ACP discussion, we document it in the computer EMR system, so that everyone is aware, whoever is looking after this patient. At the same time, I do encourage the patient to write down their ACP and keep it near their appointment card. At any point, if they turn up in the emergency for an acute event or anything, this ACP is available and they can pass it to the treating doctor so that they are aware that these certain things have been discussed and what are the treatment option and preference. Again, another thing I should remind is to always relook and revisit about the care plan, because it's an ongoing process, and also it keeps on changing with the patient's health status. We make sure that whatever the current goals and values are according to what the patient wants. Always encourage patient to bring in their proxy or even segregate decision maker during their appointment, so that whatever the discussion, the patient and the segregate decision maker is at the same page. They are they aware of what's going on. So here I would like to just discuss about how to choose a proxy or segregate. So firstly, what we have to do, or what we encourage the patient, is to think about the people they feel share their views and values about life and even medical decision. So when they have already picked out this person, it can be anyone. It can be a family member, it can be his friend, it can be his wife, husband, or anyone that he feels would be the best person to be his spokesperson. So once he have this, we name it. It can be one person or two person depending on what the patient wants. And then next thing I would ask the patient to decide how much authority he would want or to give to this patient medical care. Because sometimes what happens, this patient may decide, however, at time when it occurs, this maybe wish cannot be carried out 100%. So we must know how much flexibility would this proxy be given. And then so again, when we discuss ACP, we should also remind patient, we should not add on maybe guide or even wishes that are impossible to be fulfilled. Okay, so these are things we also have to make sure patients are aware and proxies are aware. So like I said just now, for segregate or decision proxy, we make sure this person is familiar with the person's value and goals, and then we confirm the willingness of this person to take up this responsibility, and we must always involve this person in the advanced care planning discussion, even though the patient, even when the patient is still able to give or make a decision. So they are always in the same page when discussing about this person's medical decision. So, like I just now said, make sure that the segregate has the ability to make decision according to patient's wishes. Clarify about the degree of flexibility. Sometimes it occurs that this wish cannot be done 100%. How much changes can this proxy make for this patient? Another thing we have to make sure is that the proxy doesn't actually divert away from what the patient's wish are. Okay, so I'm at the end of my talk. So what do we do after ACP? After discussing and getting an ACP, make it known. Make sure that the patient make it known to their close family members, next of kin, and also other healthcare providers. Make copies of this document to be kept with them. And if they go to the hospital, they may have to give it to the staff to include in their medical report if it's into a new hospital. But when we give this out to the patient, to the healthcare providers, we must remember where these ACP are, because we always change. There can be changes in the ACP, so make sure that it's in line and everybody is aware. And remember to review your advanced care plan decision from time to time, because it's an ongoing process. It's not static. It can be changed every time your health status changes. Okay, so the take-home message is ACP is an important discussion. However, not many are aware of it. So that's the reason we are doing this talk, to sensitize and make it aware that this decision, this discussion can be done and should be done. It's not only for patients who are terminally ill, it can be done for patients who are even healthy, because we never know when we will have or we may become ill and unable to make a decision. ACP is an ongoing process. It's not only a discussion at that point of time. It is supposed to be always revisited, especially when there is changes in your health status. And it should be physician initiated. If it's not physician initiated, and if the patient is aware of ACP and wants it to be discussed, please let your physician know. And I think they would be happy to take up the discussion with the patient and family.